Good evening, everyone. Hi, Tina.
Hey, Wilson.
Just doing a streaming testing. I just finished class actually.
Oh, so busy.
Yes, I had 4 meetings today, and I gave 2 presentations, and I gave 1 test, and this is my final presentation of the day.
Oh,
Very.
your voice is still very clear.
Oh, my voice is very clear.
Hello,
Well,
Popcorn. Yeah.
I'm working very hard to showcase our work, and hopefully we can get more people interested. Oh yeah, that reminds me, I want to add in one slide to advertise my PhD program. So
Yeah,
let me
sure.
put it in.
Yeah, I'm not sure whether we have the correct audience.
Okay, I mean, the more people who know about LKC medicine and interested to apply to come and do proteomics research with you and me, happy to have more of those. What's his name? Okay. Oh.
Li Qing, who is the chair? Is Bing here?
I think so, because we rehearsed on Friday. I think Dr. Xiao will be the chair.
Okay, let me call her.
It's okay. We'll have the. Hi, how are you?
Hey, good. Thank you for the invitation.
I didn't invite you. It's Tiana who invited you.
Thank you.
He's the host. We are his guests.
Right,
Yeah.
right. Yeah.
Thanks for inviting us, Tianan, and for putting this together. I was very shocked to hear that there are 700 over people who sign up. Where do you get 700 from? I can't even get 700 people, right, to to apply to us, or to come to any conferences.
I don't know where they. Nowadays, there are many webinars during the pandemic, and some of them hits tens of thousands of audience. Some popular talks.
My
We
God.
have quite a small area, but
Oh.
hopefully the thyroid become more popular or more people interested in this topic in the future.
Yeah, I agree. I think that would be really nice. It's two of our favorite things, right? Cancer and proteomics.
Yeah. Also proteomics.
Yeah. cancer proteomics.
Yeah, cancer proteomics.
Yeah, it's been a while. Yeah, but you're keeping up well now. I've been publishing well, I can see.
I need to check with the connection with the chair, Bing. Just please excuse me. We have
Sure.
6 minutes to go.
All right, see you later. Li Hao, do you know Anna Chu?
Yes, yes. She was my biology teacher in.
I heard she's my staff actually. So when she told me, right, I couldn't believe it. That means you must be very young. Very
I'm,
young and talented.
Yeah, 39 years old.
39?
Yeah, 39.
Then our age is not so far apart. How can she be your teacher? I don't remember her being that
Very
old.
young. She was very young when she was my teacher. She was in her early 20s, I think, or maybe mid 20s.
Oh my
Yeah,
goodness.
We were like her first batch. Yeah, we were not very far apart in age.
I see. Ayo, that's the kind of age gap that's the most dangerous.
Yeah.
I see. Yeah, she's been working for me for the last 3 to 4 years as a research assistant.
Yeah.
I hope the bandwidth holds up. It does seem a little bit unstable. Is it okay on your side? It looks a bit fuzzy on your side.
Oh,
Yeah.
can
It's
hear
like
you well.
sometimes I can see the NHG logo, sometimes I cannot see it.
Oh, okay.
And sometimes I hear people and I'm not sure why. So interesting.
Yeah. So this is like a room for the speakers and the moderators.
I think so. Yeah.
Okay. Yeah, because I really don't know who are attending this webinar.
You'll find out soon.
Okay.
I just gave another talk this morning to the senior vice president and the vice president of NTU. They wanted to know all the AI in the biomedical sector in NTU. Like we have to present to them our work, and then tell them like, oh, what do we do? And then they say, okay, you all sit down and then you all discuss how are we going to go for large grants together. It's like, wow,
Yes.
so
Very ambitious, yeah.
yeah, but a lot of NHG people were there, Cheng was there also. You know Cheng, right?
Yes. Yeah.
I'm not sure if Philip Chu went, but I know there were quite a lot of key
Benz
people.
was there.
Benzi was there. Yeah. The usual suspects, Yeah.
Apologies to interrupt.
Hey.
We have 3 minutes to go.
Hey,
Nice
Bing.
to see everyone. You've gone Dr. Or during the testing. Nice to see you again. And Dr. Gong, nice to see you. Nice to meet you. Actually, it's the first time we meet. My name is Bing. I'll be hosting for today's webinar. And we have 2 minutes before we start today's webinar. Thank you all for joining us. So today we have an hour and a half. I'll give an
Sorry,
yes.
Hi Bing, can you change your name? Your name now is Li Qing Qian. You can change
Okay.
your name.
Thank you for that. Can you change it? Let's see.
So who is using my account? I have 2 Tiannanguo Westlake University. So the other one probably changed to admin.
Okay, we can change this. Let's see. I am able to do that. Let's go. Let me change that. Okay. Okay.
Change to no. I think your name should be Bing. Your name should be your name, Bing Xiao. And the other one, 就我的那个账号你改成 admin 可以吗？
Got it. Okay. No problem. Okay, so we have countdown about 30 seconds to go.
Great.
All right, no worries. We're all very chill.
Yeah, I'm very excited about how we can share some exciting upfront of thyroid disease area.
So I start to share my slides. Can you see them?
Yes.
Yes, before that, I would like to give a very brief general introduction for today's event. Welcome everyone to the Proteomics and Thyroid Disease webinar hosted by Westlake University. So after the first two medical revolutions marked by antibiotics, imaging, and molecular medicine, proteomics-driven precision medicine is now leading the third medical revolutions. Through integration with clinical medicine, AI-empowered proteomics has great potential in early diagnosis and disease treatment. This webinar brings together renowned pathologists, clinicians, as well as senior proteomics researchers to explore new strategies for diagnosis and treatment of thyroid disease. So first we speak today, Dr. Li Hao also has many other significant achievements and appointments, but among which I would like to introduce him as the consultant otolaryngologist, a head and neck surgeon at Tan Tock Seng Hospital in Singapore. He's also the clinical lecturer in National University of Singapore and Nanyang Technological University. The list goes on. So his talk today is titled Unmet Needs in the Management of Thyroid Nodules, and he will begin his wonderful talk now. Thank you, Dr. Li Hao. You can go ahead and start.
Okay, thank you. Thank you, Bing. And I am very honored to be here. And thank you, Professor Guo Tianan, for the kind invitation. And I'm also very honored to be with my distinguished colleagues from Singapore, Professor Goh, and also Professor Kong from National Cancer Center. In the next 20 minutes, I shall perhaps share my perspectives on the problems that we still are facing in the management of thyroid nodules. As a head and neck surgeon, patients with thyroid tumors or nodules are important part of, in fact, a significant part of our practice every day. So, as you probably already know, thyroid nodules are very common, and it's increasingly commonly diagnosed because as we age, the chance of identifying a thyroid nodule increases. So data from Europe shows that about 72% of people aged older than 60 can have a thyroid nodule diagnosed if they go for a scan. And so the availability of neck scans, ultrasound, MRI, CT, or PET scans have really increased the pickup of thyroid nodules. But most patients with thyroid nodules are asymptomatic. They actually don't really want to know they have a thyroid nodule. They're usually surprised. And when they come to see doctors, only 5 to 10% of them are cancer. So majority of these nodules and therefore can be observed, or they should not be even diagnosed in the first place. But our duty is to identify these cancers and provide appropriate treatment. But what confounds the problem is that we know thyroid cancers are generally indolent, and some patients can live their whole life with a thyroid cancer without suffering from morbidity or mortality. So that makes the decision making even more complex. So we need a way to quickly reassure patients that their thyroid nodules are safe and they can leave them alone, and therefore they can be discharged from medical services and go on to have a normal life. But after extensive evaluation, about 1/3 of the thyroid nodules are still indeterminate for cancer. So that is really a problem, and these patients will go on to have diagnostic hemithyroidectomies to obtain histology and to obtain reassurance that indeed there's no cancer in their thyroid. So this generally harmless condition is demanding a lot of healthcare resources, and patients are often quite worried once they have seen the doctors for thyroid nodules because it's difficult to provide a quick reassurance. And therefore, this is the reason why the accurate diagnosis of serious cancer in thyroid nodule is an area of research need. So to recap, what are the kind of thyroid cancers that we need to rule out? And you can divide thyroid cancers into two main groups: follicular cell-derived cancers and C-cell-derived cancers. And majority of the cancers are follicular cell-derived, and papillary thyroid carcinoma, or PTC, form the majority of these cancers, and followed by FTC, which is follicular thyroid carcinoma. And the rarer types would be Hürthle cell carcinoma, polydifferentiated anaplastic carcinomas. The C-cell-derived cancers are generally medullary thyroid carcinomas. But occasionally, we also see lymphoma or distant metastasis to the thyroid gland. And these are rare, but are possible malignancies that may be encountered in the workup of a thyroid nodule. So in Singapore, based on data from Cancer Registry, 80% of thyroid cancers are papillary, and 14% are follicular, and about 2% are medullary, and 1.7% are anaplastic, and 1.5% are Hürthle cell. And polydifferentiated carcinoma is quite rare, and based on data, this is slightly outdated, but it is quite clear that papillary thyroid carcinoma is certainly the majority of thyroid cancers, but follicular carcinoma is not uncommon. So the incidence of thyroid cancer is also on the rise, and this is more recent data from showing the trend of thyroid cancer that are diagnosed in females and males over the years from 1968 to 2017 in Singapore. And the blue line is the age-adjusted incidence, and that's on the rise. And the beige line is the mortality rate, and that's remaining stable. So this kind of trend is also observed in United States, Korea, Australia, and many other countries. And this is perhaps due to the increasing diagnosis of microcarcinomas, papillary microcarcinomas that are small and quite indolent in behavior. So the management of thyroid nodules in the clinic, I think I'll summarize here so that we can put things into perspective. The first thing we do is the thyroid function test. So we do a blood test, and based on that, we classify patients into hyperthyroid, euthyroid, and hypothyroid groups. Hyperthyroid patients generally have benign nodules, and they are therefore referred to endocrinologists for workup and management of their thyroid function, and they rarely need surgery. Euthyroid patients are the majority of patients that we see. These patients with nodules basically want a reassurance that basically we need to rule out cancer in their nodules. And hypothyroid patients also have a reasonable chance of thyroid cancer, but they are referred to endocrinologists first to make sure that the cause of hypothyroidism is worked up and their thyroid function is optimized. So this slide is a famous quote from British Medical Journal, and I think all surgeons should remember this. It says that a good surgeon is one who knows how to operate. A better surgeon is one who knows when to operate, and the best surgeon is one who knows when not to operate. It is easier to know how to operate than to know when and when not to operate. It's very hard to know when not to operate. But if we do enough surgery, we will know that every surgery has got complications. Even in the best hands, we can never avoid complication 100%. So to rule out thyroid cancer by doing a hemithyroidectomy or thyroid lobectomy, we need to tell the patient the possible complications can be hoarseness of voice, which includes a breathy voice that's like a whispering kind of voice, or a voice that affects their singing, especially a high pitch. That's because of injury to the laryngeal nerves. And 1 in a few hundred patients can suffer a life-threatening hematoma. That means a big, blood clot in the neck, and this kind, some of these patients can actually pass away from this when they cannot be managed expeditiously. So once in a while, we also see infection, and many patients suffer from a neck scar after surgery. And not to mention that most of these surgeries are performed under general anesthesia. So in frail patients with underlying cardiac or stroke risk, you can occasionally encounter, a heart attack or stroke after such surgeries. Yeah, so it is, even though thyroid diagnostic hemithyroidectomies can be done pretty safely by high volume surgeons, we can never avoid some of these very serious complications. So how do we therefore choose our patients for appropriate surgery? And there are various guidelines published worldwide. And this is the American Thyroid Association guideline that's adopted, that is commonly used in Singapore. So you can see it's a complex algorithm. And the first step is to do the thyroid function. And after that, thyroid ultrasound. And so based on ultrasound, you can classify the risk of cancer into various categories. The majority of the time, you still need to do a fine needle aspiration to obtain a biopsy. And these biopsies are basically cells, so cytology. And this cytology are again classified according to various systems. And the Bethesda system from United States is one that we commonly use in Singapore. So even with such biopsies, you can see that there are still various categories of suspicion. And this category here, AUS/FLUS, is Bethesda 3, and this is basically indeterminate of cancer. And Bethesda 4 is this category called follicular neoplasm or suspicious of follicular neoplasm. And this is also indeterminate of cancer. So the risk of cancer in this Bethesda 3 and Bethesda 4 category can range from 6 to 40%. So that is a big range, and that creates a lot of uncertainty in the management of this kind of cytological results. It's difficult for surgeons to tell patients you should go for surgery when the chance of cancer can range from 6 to 40%. It's just not precise enough to kind of clearly decide what to do. And therefore, there are various ways of managing this group of patients. So this is an area that we should refine. And you can see ultrasound. Why ultrasound is also quite tricky. That's because it's rare to see such benign appearance where it's a simple cyst without any solid component within. Most of the time, you have this kind of appearance on ultrasound. You have a bit of solid component, or you have a nodule that looks similar in color to the adjacent thyroid tissue. And then you end up doing a lot of fine needle aspirations, basically. And there are more precise ways of classifying, features based on ultrasound. And one popular system is developed by American College of Radiologists, or ACR TIRADS. And sonographic features are assigned various points, and you add the points together, and the higher the points are, the more likely the chance of cancer in these nodules. But you still need to do FNAC for a majority of these nodules. So in Tan Tock Seng Hospital, our senior radiologists perform these classification systems on about 100, in this study, about 100 nodules, and 30% were cancer. And you can see that the sensitivity of these systems are very good, nearly 100%, but the specificity is really low. And therefore, many nodules are still asked to undergo fine needle aspiration biopsy, which is invasive and not something that patients want if they have a choice. So you know, this is the area under the curve of area under the ROC curve for the performance of various sonographic risk stratification systems by an expert radiologist in head and neck. And you can see that his, area under the curve is only about slightly less than 70%. So ultrasound has some limitations. Fortunately, many studies such as this big one from China have explored the use of artificial intelligence in classification of thyroid ultrasound pictures. And this study is one of the largest and involving about 10,000 images and validating a few thousand images later on. And similar studies have been performed worldwide, and summarizing this meta-analysis that's recently published. And you can see the overall area under the curve, area under the ROC curve is quite good. It's about clearly almost 90% for AI and versus human radiologists. Yeah, so it appears that AI can be used to improve the interpretation of thyroid ultrasound, and to go further, deep learning algorithms perform better than non-deep learning algorithms. How about cytology? How precise is cytology? We look at our own results. We published this in Annals of Academy of Medicine recently, and we have about 821 nodules, and all these nodules underwent fine needle aspiration followed by surgery, so we know their actual diagnosis. So what I want to highlight is that about 1/3 of the time, the cytologies persist of 3 or 4, they are indeterminate for cancer. So when we remove them, the chance of cancer turns out to be about 27%. And this number is again not so great. If there's an option to further risk stratify this 27% into highly likely to be cancer versus unlikely to be cancer, then clearly the many surgeries can be avoided. The other thing is the benign cytology. So the cytology report comes out as likely benign, but this is quite common. 35% of the time we encounter that. And when we remove these nodules for actual diagnosis, gold standard diagnosis, about 4% of them turn out to be cancer. So when we look at the international rates of this kind of like misclassified cancers, the risk is about 3%. So this is again not so good. If the patient knows that their risk of cancer is 3%, even though their cytology is benign, they're not going to be very reassured, and they still want to be followed up. And often the fine needle aspiration has to be repeated, and this again makes the management quite complex. So I show you an example. This is my patient. He's got this kind of thyroid nodule that sonographically on ultrasound does not have very clearly suspicious features. So I performed fine needle aspiration because the nodule was large. And the cytology says follicular lesion favoring nodular goiter. So basically favoring benign. And therefore I observed it, but it grew in size, so I removed it eventually. And the histology turns out to be an angioinvasive follicular carcinoma that's encapsulated. Even though this is still a low-risk carcinoma, the presence of angioinvasion is concerning, because it's possible that if we continue to observe this cancer, and the patient can develop distant metastasis, and if we operate by then he's going to ask me, why do you observe my cancer until it's becoming, so advanced? Yeah, so for clinicians, we want a way of ruling out thyroid cancers with greater confidence. If not, especially surgeons will choose to perform diagnostic surgeries for reassurance. So what are the current approaches that can augment ultrasound and fine needle aspiration? As you're probably already very familiar with, there are various molecular tests and genetic tests, basically, of cytology. And a few big companies in the United States, this Afirma gene expression or genomic classifier, and the thyroid sequencing from UPMC of Pittsburgh. And that's a next generation sequencing platform. And then the recent tests, ThyGenX and Thyroid test that looks at not just DNA, RNA, but microRNA. So I work in the US for a year recently, and I've personally seen some of these reports. And the issue is the cost of these tests. So, you know, they cost like 5,000–6,000 Singapore dollars if we do that routinely in Singapore. And we actually realized that it's not cost effective. So in Singapore, we are a healthcare system that uses about 5% of GDP, but achieves one of the highest life expectancies in the world. Yeah, so this cost effectiveness is really important. So if a test is very expensive, then it should have very good sensitivity and specificity. So we actually sent some samples to UPMC and took part in this validation, multinational, multi-center validation study of thyroid sequencing version 3. And you can see that the sensitivity is 94% for thyroid sequencing version 3 in the risk stratification of Bethesda 3 and 4 nodules. And the specificity is a bit lower, 82%. It seems quite good, but when you look at the performance of this test on the different types of thyroid tumors, you can see that follicular type of neoplasms, which include follicular adenoma, hurdle cell adenoma, follicular carcinoma, and the test doesn't seem to do very well. Yeah, although the number of follicular cancer is really small and the confidence interval is wide, we can see that in the benign tumors, they are more common. The accuracy of this test is not so great. So many benign follicular neoplasm are classified as indeterminate based on genetic testing. And that is because benign follicular neoplasms such as adenoma or NIFPs share RAS mutations with the malignant counterparts, which are follicular variant papillary carcinoma or follicular carcinomas. Yeah, so their mutational signatures overlap, but papillary carcinomas have quite distinct mutation in BRAF V600E or TERT mutations and PAX8, PPAR gamma, etc. So this genetic test is very good for the ruling in and ruling out of conventional papillary carcinomas, but not so good in the differentiation of follicular type of neoplasms. Therefore, to me, a very important unmet need is how we can identify follicular carcinoma, follicular variant of papillary carcinoma without surgery. And a lot of effort in ultrasound and fine needle aspirations are made just to rule out this kind of tumors. So these tumors are also not uncommon. So based on our experience, they form about 1/3 of the cancers that we manage. And not only is it difficult to differentiate them based on genetic tests, on ultrasound, they're also difficult to rule out. So the ultrasound features of cancer tend to be present more often in papillary or medullary carcinomas, and less so in follicular carcinomas. And then cytologically, we look at the distribution of Bethesda category according to the blue ones, which are follicular carcinomas, and the orange ones, which are papillary carcinomas. And you can see that follicular carcinoma usually don't give you a very clear-cut cytology. Usually their cytology is indeterminate, whereas papillary carcinomas are quite easy to diagnose once you do fine needle aspiration. And finally, this problem of difficulty in ruling out follicular type of cancers is more pronounced in large nodules. So this is our data in nodule, and they're at least 4 centimeters in size. When they are cytologically benign and you remove them, about 10% of them are still cancers. And this is not good at all because 10% is quite high. So when you look at the kind of cancers that are misclassified by cytology, you can see the majority are follicular variant of papillary and follicular thyroid carcinomas, basically follicular kind of neoplasms. Yeah, so surgeons are still commonly removing nodules greater than 4 centimeters just to make sure that they are benign. But if we have to do this all the time, then as you can see the data here, about 90% of the surgeries are unnecessary. So we really need a solution to better risk stratify these nodules. So in the market, the new way of risk stratifying, kind of identifying follicular cancers involving the use of microRNAs. Yeah, so ThyroidNext and Thyromer is the test that purportedly can do this. So they do the genetic sequencing first, and if they think the tumor has signatures that suggest follicular cancer, then they add on the microRNA test. And that's because according to their results, microRNA signatures are found in follicular carcinoma. So some are upregulated, some are downregulated, and using this, you can more confidently rule out or rule in follicular tumors, follicular type of cancers. So this is where my paths crossed with Professor Guos and his colleagues, and I was very excited to read this paper where they show that proteomically you can also differentiate follicular adenoma from follicular variant papillary carcinoma and follicular carcinomas. Yeah, so in fact, there seems to be quite a lot of proteins that are uniquely expressed in follicular adenoma and their malignant counterparts. So if we have a way of identifying these unique proteins and will prove that they're highly specific for follicular variant papillary carcinoma or follicular thyroid cancer, then it will really be helpful for clinicians. And various other papers have also been published from Professor Guo's lab, where they use AI or various new technologies to further risk stratify the proteomic expression of thyroid nodules. So this is very exciting to me. To summarize, the unmet needs are in ruling out follicular type of thyroid cancer, and also to make the test cost effective so that it can be widely adopted in many parts of the world. And finally, we should not forget that we can also refine ultrasound, because that's the first step. So if ultrasound can become more specific for thyroid cancer, then actually it can reduce a lot of fine needle aspirations. So thank you very much.
Thank you, Dr. Lee, for your sharp clinical insight for the rising healthcare dilemma, thyroid nodules. We now have a better understanding of the current gold standard diagnosis management plan for thyroid nodules, as well as the important role precise diagnosis plays in decision-making of surgery or not. It was actually quite shocking to hear that over 90% of certain thyroid cancer surgeries are not necessary. So really, we can hear the calling for more precision medicine that maybe Proteomics can provide the answer to. So next, we're very honored to have Dr. Gong Wenbing, who is the founder of Biodata Science and Education Laboratory at Nanyang Technological University and Director of PhD programs, Director of Biomedical Data Science Graduate Program, Head of Good Research Practice Office, Academic Lead of the Data Science Research Program at Nanyang Technological University, to bring us the talk on contextual reasoning based on biological networks enhances proteomics analysis. Thank you so much, Dr. Gall. Go ahead and start your talk, please. Dr. Gall? It seems like we can't really hear you right now.
Apologies, I needed to unmute. All right, just a sec.
All right, that's kind of all right.
Yeah,
So
it happens. It happens. Just give me a sec while I set my slides. Sorry. Okay, so let me come back in. All right. Yes. Can you see my screen now? Can you hear me?
Yes, perfect.
Perfect. Thank you very much. Thanks for inviting me. Dr. Guo. I'm really honored to be here, and of course, right, to also, I'd like to thank everybody for making time out this evening to listen to us. I'm very grateful to Li Hao for actually painting the background. So I hope after his talk, you get a very good sense, right, of the potential for AI and how it can potentially improve diagnosis in thyroid cancers. I'm going to take a slightly different track. So it's really very different from Li Hao, actually, because Li Hao is a clinician and Tianan, right, is a proteomicist. My background is in analytics. So as Bing has earlier alluded to, I'm also the director of the data science research program in the LKC Medicine. I would like to perhaps give you a little bit about what I think, about the potential of proteomics for diagnosis and how it can be potentially rendered better. So the title of my talk today is contextual reasoning based on how biological networks can enhance proteomics analysis. All right, so I'm going to start with a well-known aphorism, all right, commonly attributed to George Box. Many already know the saying, all models are wrong, some are useful. And this saying can also be extended to any functional models seeking to use artificial intelligence or machine learning techniques. The question is, how do you tell which ones are useful? So it's really very important that we understand the limitations of models. After all, a model is only a useful approximation to reality. In high-dimensional big data, we're almost guaranteed to find some spurious correlations. In complex systems, interfeature collinearities also causes overcorrections or inconsistent rules and explanations. So ultimately, this produces non-justifiable models that, while sometimes correct, can also sometimes produce spectacular errors. So in this first example, I want to show you that high class effect proportion and high feature collinearity, which means that many different combinations of rules can actually predict breast cancer. And many of these reported rules or markers are merely non-causally correlated or just simply downright wrong. And by systematically studying how confounding issues affect cancer biomarker objectivity, we can design good statistical rules to get reproducible breast cancer biomarkers. And so in this work, we published in Drug Discovery Today in 2018, where we report a robust breast cancer biomarker known as the superproliferation set, or SPS. High dimensionality and interfeature collinearities can also take the form of a unique example of leakage specific to complex systems, and this is known as the doppelganger effect. In the doppelganger effect, the samples which appear very similar to each other by chance can also create model biases, which when split into training and validation sets. And so in such scenarios, depending on the extent of mutual similarities between the samples in training and validation, we often find that random models trained on non-meaningful subsets of features can also be very accurate. So in other words, an accurate model does not have to be right. The consequences of an unjustified model does not have to be poor accuracy. So to make models better, we need to establish the following facts. A non-justifiable model can be accurate, but can make spectacular error and does not give good explanations. However, it can be accurate. A trustworthy or useful model must be justifiable. That is, it makes its decisions based on correct domain information. So we define usefulness in terms of two levels. The first one is in reducing feature selection error. So in other words, we want to select proteins or genes that are genuinely implicated or causal in the particular cancer phenotype. And secondly, usefulness, right, should also mean we embed truth and mechanism in the features that we choose as well. And so we ask the question, can we use other independent information and overlay with proteomics data to help us reduce error and embed truth? So we know that networks contain biological truth. In 2007, Fraser and Plotkin reported that the best predictor of a protein's knockout phenotype is the knockout phenotype of other proteins that are present in a protein complex along with it. And any model using this cannot be improved further by adding more data. And indeed, network information can be used for studying diseases as well. together with proteomics data. And given the explosion of interest in network science in the early 2000s, there are many works exploiting networks to improve biological reasoning. However, given the complex topology of such systems, it is difficult to devise good statistical models on these. And so many papers or works only use networks for visual purposes. In our own research over the years, we have been developing statistical methods and applications integrating networks with proteomics data. In this early work, we evaluated the benefit of network integration on Guo et al.'s human kidney cancer swab data. And initially, we found that on raw protein counts, correlations between technical replicates is no good at around 0.4. However, upon refining the feature vector scores by integration with networks, the correlations between the same technical replicates improved to 0.95. We also find that network feature scores have low false positive rates and can withstand the introduction of noise into the proteomics data. The network features also provide clear interpretability, and this is very useful for machine learning. As networks benefit from improved functional coherence, we also get a good idea of what they do. This helps us to better understand and explain the results. We can also pick up interesting features more easily due to amplification of effect sizes. You can see that the summarizations based on networks are distinguishable, whereas it is unclear for different individual proteins, given that each person's mutations are different. If the network scoring function is done well, you can even escape batch effects from your data. In this example, we show that in data where batch effects are present, projections based on the networks emphasize the class information, differentiating the healthy and cancer samples. Whereas for proteins at the protein level, batch effects are actually found in the first few principal components. So if the features used for an AI are truly objective and meaningful, then they should never be outperformed by non-meaningful randomly selected features. Given the same kidney cancer data, we show that direct use of proteins lead towards supersedable models, whereas this is not the case for network-based models. As only network models can objectively predict the cancer, we can more likely trust the explanations that they generate. Hence, such models are likely to be justifiable. So far, I hope I have convinced you that networks have excellent properties and can support the use in proteomics, particularly with AI-based models. But can we do more? Can we make the rules more understandable? Can we improve on the performance evaluation? And can we use these properties to tackle challenging issues on protein ambiguity? So let us start with a concept. Let's say the failure to form a protein complex causes a disease. If any component protein is missing, then the complex or the network cannot form. Different patients suffering from the disease can have a different protein component missing, and so it makes sense to construct a profile based on complexes. Let us try another idea. The proteins belong to a complex or a network, and the probability of a complex existing depends on the number of observed proteins and their reliability. Suppose each protein has a reliability of 75%, and 4 out of 5 of these are found in the complex. Then the complex has a 60% chance of being present. Any missing protein thereby also inherits the same probability of the protein being present. Any observed protein can now also be considered with respect to its parent complex being present or not. So in this case, the corrected reliability for proteins A to D is now 90% instead of 75%. And this is a powerful concept. And we can use this on protein complexes as a generalization of the idea put forth by Fraser and Plotkin. And does this idea work in practice? So we have recently implemented the idea into a method known as ProTrack, or short for protein recovery. A very critical distinction of this approach is that unlike earlier network methods that transform the protein list into a network vector, ProTrack embeds the network information directly into the protein itself, expressing our confidence in the reliability of a given protein, given information on its constituent networks. We benchmark ProTrack on several data sets, including DIA swath, but also DIA and DDA PASEF data. And the results are very astounding. Given any method for benchmarking, ProTrack dominates all other network-based methods, especially those which rely on p-values. The most useful comparison is shown in scenario D, where we predict using DDA, and then we validate using independent DIA data on the same cell lines. Another way of telling that the feature values are meaningful is to check the score distribution. When the scores are high and meaningful, we also expect observed proteins to be concentrated there. We also expect high scores to be correlated with high validation rates of missing proteins. So as you can see on the left panels, ProTrack is very tight in this area. Previous top methods such as FCS, GSEA perform well, but the trend is not as strong. Part of the reason is due to p-value variability and incompatibility. If the statistical distribution does not fit the proteomics data well, then the p-value will also not be reliable. Finally, we also check which method is most robust against noise. To achieve this, we randomly drop half of the proteins and try to predict them back. As you can see, ProTrack dominates here. If you embed good information into the feature, you can get much better outcomes from analysis. A very challenging area in proteomics is ambiguity. Protein ambiguity occurs when proteins are supported by common ambiguous peptides. In such situations, we cannot easily figure out which proteins should indeed exist, and we can use ProTrack to reason it out. Suppose if we have two ambiguous proteins that are supported by two distinct networks with little overlap, then we can assume that the neighboring proteins provide independent information, signifying that the ambiguous protein should indeed exist. Incorporating this reasoning into our model allows us to infer ambiguous proteins based on information from the neighbors. And indeed, we can validate these proteins by a second round of spectral mining. We are not done with just ProTrack. We can extend the reasoning used in ProTrack into many other applications. In our next upcoming algorithm project, which is a mixed model missing value imputation technique, we can explore whether missing value imputation benefits from imposing network constraints. We can also use gene expression information based on correlation networks to further expand the set of predictable proteins. This means we will no longer be limited to just protein complexes. In addition, our new method PROS uses ensemble methods to help make more accurate predictions. Finally, instead of keeping spectra and networks separate, we use these to reinforce each other. This allows us to connect identity with quantity. Our latest protein assembler, ProInfer, does just that, using an iterative scoring algorithm to update network and protein confidence scores, and the results are very promising. One of my lab's current interests is in the development of personalized therapies using personalized AI models. And this approach can be very powerful towards overcoming clinical heterogeneity issues. Some of the methods we are deploying and refining include the double-weighted KNN, transductive neural fuzzy inference, and spectral neural networks for longitudinal data. To overcome issues of high dimensionality, noise, and to enforce a consistent representation of data, we will be developing training features based on biological networks. Network-based feature engineering are techniques pioneered during my PhD years, which have been shown to have powerful statistical properties. And we think that by combining these information in the future, together with also genomics and metabolomics data, we would be able to make very interesting headway into the area of predictive analytics in the biomedical setting. In summary, proteomics benefits from models supporting biomarker selection. Models built on features containing biological truth are robust. Justifiable models can be readily extended into advanced AI applications, and networks contain useful information for supporting proteomic analysis and applications. But we also have limitations. High-quality tissue-specific complex are needed. We also need to make further refinements to tissue-specific protein atlases, which are useful for validations. And finally, we also need to make further data integration to better predict quantitation of predicted proteins. We're coming to the end of my talk. And so here are some of the relevant papers that I have mentioned in the last 20 minutes or so. And I'd also like to acknowledge Limson Wong, Dr. Peng Hui, and also my PhD students, Kong Wei Jia and Bertrand Wong. So if you're interested to find out more details, I would be very pleased to talk to you guys. You can contact me at my email at wilsongo@ntu.edu.sg or visit my website at biodatascience at GitHub. All right. So I also like to say thanks to everyone in my team. We have a lot of young people, and so if you're interested in biomedical data science, feel free to ping us and let us know your interest in joining us. I would also like to let you know about this new center that we just set up this year in April 2022. I run this center called the Center for Biomedical Informatics. This is a bioinformatics support facility. So if you're interested to find out more, and you have a lot of data, but you're not sure what to do with it, yeah, feel free to connect with us as well. So with this, thank you very much for listening.
Thank you, Dr. Gao, for your wonderful talk, and congratulations for establishment of the Center for Biomedical Informatics. That's very exciting. We can totally see how deep learning and statistical analysis can advance our research in proteomics, but not limited to, but many other areas to finally achieve our goal. Probably everybody's dream to get personalized AI models for personalized therapies. So after two wonderful talks, we're very excited to move on to the panel discussion, during which you will see three more wonderful speakers coming up. And the first speaker and the panelist, we're going to have the first one's Dr. Oi Lian Kong, who is the former head of Division of Medical Sciences at National Cancer Center Singapore, and Dr. Tianan Guo, who's the principal investigator and assistant professor at Westlake University. And last but not the least, we have John Fangfei, who's a PhD student of Westlake University, who had her master's at ETH Zurich. So let's go ahead and have everybody start our panel discussion. Can't wait to hear about your wonderful insights. Thank you.
Thank you, Bing.
Yeah, thanks a lot. Maybe I start with a question. Maybe a question to both. So Dr. Li, just now you mentioned there are multiple biomarkers to separate different thyroid nodules, including DNA and RNA expression and microRNA. And you also mentioned some ultrasound features, particularly in combination of AI models. They can achieve very high degree of accuracy. And how do you, and on the other hand, you mentioned it should be cost effective. You don't want a test which costs 5,000 US Singapore dollars. So that's, if you combine different features, I guess you will be able to get a very good accuracy, maybe solve all the maybe most of the problems. Some subtype you mentioned there are 75% accuracy, you're not very happy. So I want to ask you, so how do you see this trade-off? Do you think someone will like to pay, or some government or healthcare agency will like to pay additional 10,000 Singapore dollars to increase the accuracy from 75% to 90%? And a relevant question to Wilson, maybe after you answer, have your comments. So you mentioned protein complex. So is this complex analysis only applies to protein data? So this applies to DNA, RNA, and microRNA, or whatever other type of data, or this is unique to proteomic data? Thank you.
Okay, yeah, wow, very challenging question, Professor. It's very sharp. Yes, I mentioned that patients with thyroid nodules actually want reassurance. And we know that thyroid cancer in general, especially papillary thyroid cancers, are not as bad as, say, lung cancer or breast cancer, right? So honestly, we also don't want to scare the patient too much, and in fact, the diagnosis of thyroid cancer in some studies are associated with bankruptcy in the United States. So so we really don't want to hurt the patient by fear mongering. So I think we want a simple way of reassuring them, and I think maybe we should pay more attention to what we already have. That ultrasound is quite cheap and harmless, right? And if we can do more for refinement of ultrasound, you actually can reduce a lot of healthcare downstream expenditures, right? You reduce fine needle aspiration and reduce follow-ups and surgeries. So that's one thing, and maybe it's quite affordable to work on ultrasound first. And then next, you still have many patients who need cytology, right? And then maybe we can just simply refine the Bethesda 3 and 4, by simply looking at pathology more precisely. Yeah, so there, for example, in Bethesda 3, the atypia category, in publication from National University of Singapore, look at just simply separating them into architectural atypia versus nuclear atypia. Yeah, that's like you can look under the microscope and tell them apart. And architectural atypia has a lower risk of cancer compared to nuclear atypia. Yeah, so simple things like that. Yeah, we should not forget that we want things as simple as possible. So then still, because thyroid nodules are going to be increasingly common, people are going to have their neck ultrasound, MRI, PET scan. That's like a trend. We can't stop that. So they will be diagnosed, and they will end up 10-20% will still have indeterminate cytology. So then maybe proteomics, if you find very precise proteomic signatures that are associated with thyroid cancer, more precise than genetic signatures, then you can do this test quite affordably. Then yes, then I see a big application here, because the genetic tests developed by Americans, they are used to charging high prices. They can just ask the insurance companies to pay, right? So they're not going to lower their price so much. But there are some innovators who reduce the number of genes they screen to, say, just 10 genes, simple panel, BRAF V600E, for example. And they actually validated that approach in Africa, in a resource poor country. Yeah, and it seems to work as well. So maybe we try to make things as simple as possible. Yeah, so I think that the key is to find very specific biomarkers for thyroid cancers. Yeah, so I don't know whether in proteomics you have already found such biomarkers, but like genetics, BRAF V600E is highly specific for papillary thyroid cancer. So it's pretty useful as one standalone test. Yeah, so I think that's my insight. Yeah. Thank you.
So I have a related question. So you mentioned just now, maybe some people will use a small panel, 1 gene or 3 gene or 10 genes. This also widely applied in China. Very few people actually pay $4,000 for a GC or Cyrus V2. But do you know any precise data regarding the actual accuracy of using 1 gene or 3 gene or 10 genes? Because I heard different voices from when I talked to clinicians in China. So some told me they are very happy with just BRAF, because BRAF seems can solve more than 90% of the problems. And some say they want to measure over 70 or over 100 genes, because they want to see more suppression of the indeterminate thyroids. Do you know, is there, I know you showed that also several papers, review papers, they mentioned the performance of thyroid-seq and GEC, which are very, very expensive. And but do you know the accuracy for the small panels?
Yeah. Okay. So I have I can recall one paper that's published in Thyroid. You know, that paper, they validated the 10 gene panel, or perhaps 8 gene panel, somewhere around there, and in Africa. So I can send it to you. But the thing with using fewer markers is that you end up using very specific markers, right? So for example, BRAF V600E, it's useful in ruling in thyroid cancer. That means the test is positive, means, okay, there's a cancer and, you know, should go for surgery. But because it's so specific, but not so sensitive, you still can't rule out thyroid cancers, right? And if we can't rule out thyroid cancers, then patients are really not very reassured. They will still be followed up. They will still undergo surgery. Yeah. So actually, even though, you know, ruling in is useful, ruling out is actually more important to clinicians. But ruling out is a harder question because, you know, those follicular type of cancers, they don't usually express V600E. They express RAS mutations. They're also found in benign nodules. So that's a challenge. So I think proteomics can you know, kind of help to solve this problem. And then clinicians need to decide in what situation should we spend the money to you know, to perform these tests, and we cannot spend it indiscriminately, because, you know, I practice in a hospital that sees like 70% of the patients were paid by government, and then 30% paid by private insurance, right? So you know, we cannot say, oh, government pay for this test, and then they're going to ask us to prove the cost effectiveness, you know. So we haven't been able to prove that. So that's why I asked Tianan before, like, how affordable can you make this test? I think that's an important thing to consider.
Much cheaper than GEC and thyroid-seq. You know, in China, do you know what's the cost for surgery to cut out the thyroid?
Oh, no, I don't know. Can you let me know?
Yeah, probably similar price to the GEC test or
yes.
test.
Actually, in Singapore is similar too. It will maybe 40% more expensive than the GC test. So people will just say, why don't you just focus on doing good surgeries and, you know, just do it. Yeah, so that's why the GC test is, even the Thyroid-seq test is not really big time in Singapore.
Yeah, I'd like to hear from Wilson about, so do you think the protein complex issue will reduce the cost?
Well, I think that is a very difficult question to answer, because
I know you can tolerate the missing values. Let's say you only measure several proteins, several DNA, and there's a lot of missings for micro.
You see, my goal, right, is to increase the reliability of the proteomic screen, you know, because you asked an earlier question, which is a very good question, you know. This integration with network information, right, is useful. You know, does it perform similarly well on other modalities such as genomics? I think that question needs to be rephrased. The question is, do you need to as much? You see, the thing about the mature sequencing technologies, right, is that they can be amplified, which means that you can also have very good confidence in terms of the quantity, you know, and identities that are present. Even if they are not so confident, you still have pretty wide coverage. So you are able to see a lot more. The interesting about proteomics, right, is that it is indirect data. And in many cases, right, you know, it's nothing more, right, than a series of peaks, right, you know, and patterns, right, basically delineating each protein that you find in a particular sample. The interesting thing is that for different samples, right, even if they report the same protein, right, the contributing signal, right, in terms of the peptides for that protein in that sample, right, may be different. So my goal is to try to use information from, you know, from some kind of prior knowledge. It doesn't have to be protein complexes. It can be any kind of prior knowledge, okay? But the prior knowledge is used to leverage on the idea of if your neighbors or people that you assemble with exist, I can use that information, right, in a Bayesian manner in order to say that you are there. So, or that you are there if I don't see you, or if I do see you, I can use the Bayesian reasoning, right, to adjust my confidence that you're truly there. So if I do it this way, I would also be able, right, to have more reliable ways of determining which markers are more worth looking at. You see, I have to be very confident what they are. If I can adjust and change and at that confidence level, right, then I think you're going to be more likely and more successful, right, in order to report any useful differentiating marker as well. So I think it's a needs-based issue or problem that that we should be talking about here. But yes, can it make cost cheaper? Okay, to counter that.
Yes. So may I jump in for a quick question?
Yes, of course.
Yes. So I saw Dr. Lee show an example of FNA ultrasound images. Can we integrate those images data with molecular data? Like do a meta-analysis for the data already had in the publications to make a better prediction model on anything? To reduce costs or anything, we can improve like sensitivity or specificities. What do you think, Dr. Guo?
The question is for me, is it?
Yes.
Oh, sorry. I like where you're coming from, to look at integration of multi-modality information. I have to say I am trying to do something like that in mental health, where I am trying to combine MRI images with proteomics data, metabolomics, RNA sequencing, and also behavior modalities. I have to say that attempt, right, I think, although I think in some instances has the potential to increase your predictability or your model accuracies, right? I think the challenge with these high dimensionalities is that it also reduces the justifiability or explainability of your models, In order for me to understand, for example, how your protein profiles may change in relation, right, to your MRI images or in this case, your ultrasound images, right? I need to have some kind of causal understanding between the two. If I'm not able to look for these, right, all I'll be able to pick up, right, is that given my very small training sample, right, I can pick up different combinations of these. I can get a rather accurate model, right, based on, because I have very high dimensionalities now. But if I cannot work out why they are related, how do they explain each other, right? Then you're going to come up with the other problem, which is you bring that, right, to the hospital, to someone like Li Hao, and you try to say that I have a 99% accurate model, I have solved all your problems. He's not going to believe you. So it's also going to be ultimately a question of justifiability leading to trust, which leads to clinical applications as well. But I agree with you, Fang Fei. I think multimodality is indeed the way to go. It can create, I think, some potential, but I think we are going to also have to create, right, the necessary scaffolds and frameworks in order to try to understand how these things can work together and relate to each other as well. It's the same problem that we're currently facing in the mental health study that we have right now. So we are quite apprehensive about rolling these things out too. Thank you. That's a very nice question.
Totally agree. That's coming my following question is, what's your expectation for the ideal sample size or the effective sample size? So yes, as clinicians, maybe they can get as much as samples we want, but that's coming a question for statistician. What would be a realistic sample size for making any reliable predictions, or what would be the data? If not, so how many sample size would be your expectation also for Dr. Lee, and how many sample you can provide, or we can't? That's a common question for us. We can't collect as many samples as we want if we, especially for the FTC or the smaller portion of the patient type.
Yeah, I know Wilson has written a very famous paper about batch effect. And this is one of the most common questions we were asked by the clinicians. And the other, I think you should write another paper, how many samples we need to a clinical study. Should be also very, very popular, will be even more popular.
I would think so too.
Because I noticed the famous or the very costly Thyroid is only validated in only hundreds of samples. For us, hundreds of samples, it is a large number. It's not a large number for us, didn't we, Dr.
Yeah.
Guo? Yes, it's
It
not
is
very
large
much.
enough. It is
Yes,
not.
but they already sold into the market, and we have more samples. So how many samples would be a best number for both commercial side and clinical side?
Sorry, I just want to understand insert another comments. So seriously, when I talk to clinicians from different region in China, so sometimes they told me some numbers. They say I very much trust some test, let's like a BRAF or whatever, or AI model for based on ultrasound, and they say they have an accuracy of 95% or 99%. Whatever number, very, very impressive. And they really trust it. But then I ask them, how many samples, how many patients have you analyzed? Do you have multi-center cohorts? Then very few people can answer this question. Seems most people only cares about the accuracy, the ROC, the sensitivity and specificity. But very few people really ask how reliable. I believe more samples, more center involved, you have more reliable numbers. So from your point of view, so what's your advice to this current situation?
Is this a question for me or for Liao?
I think for Wilson first.
Oh, okay. Okay. So you noticed earlier in my presentation, right? I was talking about justifiable model, right? In other words, right? A accurate AI may not necessarily be justifiable. And in fact, right, in my recent work on Doppelganger effects, I can show you that very accurate models can be perfectly contestable. In other words, right, we can actually demonstrate, right, that their learning rules are actually irrelevant because these highly accurate models, right, are all built on random features actually. So we know for a fact, right, that especially in diseases like cancer, where it is a magnification of existing functional pathways in a normal cell. They are still highly correlated with each other because they need to work together. But because of that, right, the correlations, the mutual correlations that exhibit are also very high. So in other words, right, you can predict the cancer, but you cannot get the explanation. And so with that kind of situation, right, you can't really trust that the model, right, is indeed, right, going to be universally true as well. Now, as for sample sizes, right, there are two parts of this. There is the statistical, and there's also the logistical. I'll start with logistical, but I think Li Hao can elaborate more on this. Now, as you probably know, right, if you want to do a suitably powered analysis, right, you are going to need as many samples as you possibly can get. This is even if, right, you are able to determine a minimal sample size for expected power that you expect to see the effect size. You see, you can arrange and plan for these things, but the rule of thumb is you should get as many as you can, especially if you have no assurance, right, that your anticipated effect size, right, is indeed of that magnitude. This is especially going to be very bad when you are trying to look at multiple classes or more than two, of which some are extremely rare. So I would say that you should probably try to avoid going strictly down the sample size route. The rule of thumb is you get as many as you can, and you try to work out whether if they're sufficiently representative of the population that you're trying to predict. So that's a logistical aspect. Now, if you look at terms of the analytical aspect, right, at least in data analytics, as someone like me, I'm poor, I can't afford a lab, I can't afford to do these experiments. So I generally rely, right, on consortial data, of which, of course, technical effects, right, and batch integrity, batch correction methods, batch correction problems, right, would be really, really challenging. But we also find that there's a way to sidestep that, and use that, right, perhaps, right, to help us build assurance, in the reliability of our feature sets and models. So in recent times, right, we have put forth two works. One, right, which is on how to do batch correction properly. It was just recently published in Computational and Structural Biotechnology. It was actually a response to Rudy's pro batch paper, which I really, really enjoyed reading. But we also felt that there were a lot of further practical batch correction issues, right, that remain yet unanswered. Especially like what is the impact of early correction? How do we ensure, right, whether or not, right, right, imputation is done sufficiently such that we have the same peptides being compared across different samples, that leads to better reliability. So that is if you are attempting to integrate. But what if you can't integrate? What if the different samplings and information, right, are just too challenging in order to resolve? There is another approach that you can take, and it is what actually it was a method that Limson and I published in, I think, 2018. We call this the universality test. Okay, or also known more recently in our recent publication as divergent and convergent validation. So in these kind of approaches, right, what you try to do is you try to challenge, right, your model repeatedly, right, with new or additional information without integrating them. We can hypothesize that any useful signature should contain, right, universally validatable and reproducible information such that it would always be predictable, right, given any future data that you challenge it with as well. So in this regard, right, we do not regard sample size, right, as the key issue here, but rather, right, we look at the reproducibility of the model such that even if it does fail even once, right, we may conclude, right, that either the picture that we're looking at does not have useful information, or secondly, right,
Sorry, Wilson.
Yes.
Did you add a new real data or artificial data?
Yes. Artificial data, you mean like simulating artificial information, huh?
Yeah. You mentioned you add new data and check the reproducibility of the model. Did you
Yes.
add new real data or
real data? Only real data, because we do occasionally use transformers, right, to generate pseudo data, but usually, right, those are usually used to generate background, or to devise some kind of like p-value, empirical p-value on information. So we preserve, right, roughly how the data distributions look like, but we are poor, so we can't get enough information to generate background. So that's what we do sometimes as a second tier empirical approach as well. So there's many ways to do this, but I think, at least in clinical side, right, trust is really paramount. So I think it's really important that we look at as many examples as we can across different geographies, so that at least we know that the model, the feature selected, are not necessarily cultural or population specific as well, that they can indeed be universal and generalizable. Okay, I'm going to shut up and let Li Hao take the question.
Oh, wow, I was trying to hide behind you. So I think the effect. I mean the sample size depends on the effect size, right? Yeah. So if in my simple mind, if a proteomic signature of benign thyroid nodule can be quite, you can find some signature that's uniquely present in benign nodule and not present in malignant nodules. And you can really single them out, and it's reproducible in many places, in many samples. Then you just focus on them. If there's a way to just test them, then you probably can validate your test in a small sample size, or maybe a few hundred. Yeah. So for hospitals in general, we can provide a few hundred samples. Yeah. If you want us to provide thousands of samples consistently, then they'll be a bit challenging, especially for small countries like Singapore, right? Yeah. So that's why the like the American test, they kind of validated and commercialized based on a few hundred tests, in real patients. But later on, post-marketing, they actually have a lot of papers coming up to further validate their performance in different healthcare settings, different countries. And in fact, even randomized controlled trials have been done to compare the, Afirma versus thyroid sequencing, for example. Yeah. So maybe once we get the test, started, and you can further validate it later on. Yeah.
Thank you. Those are very nice questions, I will have to say.
Hi, Popcorn, do you have your comments?
Hi, Popcorn.
Well, I just wanted to first pick up on Dr. Lee's comment about the effect size. And I think it is known that in South Korea, there's probably the world's highest incidence of thyroid nodules, all comers, right? And that's because of the the culture of healthcare screening.
Yes.
To have your neck looked at is part of your executive health check, so to speak. So I think the effect size probably has to vary with the geographic location. But I just wanted to, first of all, before I direct more specific questions, I wanted to thank Dr. Lee for painting the landscape. And it's really changed in the last 2 decades because of the increased sensitivity of imaging. And people call this an epidemic of thyroid nodules. I don't actually agree with that term, but we all know what that means. And I'm a little bit concerned. And I think Dr. Lee kind of tried to strike the right balance. In autopsy series, anywhere from 4% to 11% of bodies that come to autopsy, in fact, will be found to harbor a thyroid cancer, meaning to say that the thyroid cancer didn't kill them. It was the bus that killed them. And so I think there is this, medical students and residents are taught that thyroid cancer is indolent. You're more likely to die of it, die with it, rather than die of it. And I think that's generally true. But I think we should not lose sight of the fact that thyroid cancers are a fascinating group, because at one end, you have more than 90% of them that will never kill you. But at the other end, you have 5% or so who are the really nasty ones.
Yes.
They will be non-avid for radioiodine. There will be no targeted therapy that's of proven help. And so some of the most aggressive cancers are also seen in this very heterogeneous mixture. And I think the challenge for people like Dr. Lee is really to try and differentiate those who will die of something else and those who will in fact need more aggressive treatment. So I'd like to suggest that let's not use the words under treatment and over treatment. Let's use the word right treatment, because that's what matters to the patient who's in your office. That patient wants to be treated right, not over, not under. And I think that's the challenge for data analytics as well as for science. My second comment, really kind of directed to both Dr. Lee and Dr. Goh, has to do with what are called biomarkers or feature selections. And I sense that because we are all very ambitious people in this webinar, we want to go for perfection. But in fact, I sense that there is a tendency to conflate feature selections or biomarkers that serve a binary purpose and biomarkers or feature selections that serve a more complex purpose, that are either prognostic or predictive. Now, Dr. Lee, you will know, and I also know because I used to practice medicine, the human body has a propensity to form lumps. There are lumps all over our bodies. You have a lump in the skin, you have a lump in your armpit, you have a lump in your breast, you have a lump in your thyroid. Now, when a person who develops a lump comes to see the doctor, and it's often going to be a surgeon, that patient is not going to be asking, what are the networks that are operating in my lump? There's a more basic question. Doctor, is this lump benign or malignant? And I'm just wondering whether those of us who are trying to attack this problem of thyroid cancer, whether we should be in fact trying to separate the process. The first step should be a binary decision. Is this benign? Is this malignant? Now that may be an easier goal to achieve with high specificity and high sensitivity. Now, having achieved that binary decision, I think the management direction becomes a lot clearer. The management would be either surgery or active surveillance, or maybe just dismissal. I think it shouldn't be dismissal. I think there should always be active.
Reassurance.
Right. And then I think there is the more challenging task, which I think Dr. Goh has been, working very hard on, and that is to say, are these feature selections explainable? Do they have biological meaning, or is it just another mitotic marker? Maybe we just say, let's use Ki67. Forget all about this fancy stuff. It's too expensive. But I see that as perhaps the step after, because as you know, and as the literature says, there is now, I think, some caution around the NIFT-P tumors and the so-called microcarcinomas. And again, I would caution against being too complacent. Just because this is NIFT-P, or just because this is a microcarcinoma, thank you very much, goodbye. I'll never have to see you again. Because in fact, some of these are the beginnings of very aggressive tumors. And I think that's where people like Dr. Goh come in, where we give a very small sample and he says, look, guys, don't fool around with this. It's a small cancer, but it's going to kill the patient. But that's the second step, I think. I'm not sure if this makes sense, that we should be very clear about what the feature selections are intended to do clinically, because really all of this has to come into the real world. If it stays on PowerPoint slides, it's useless. We've wasted our time. No matter how wonderful and colorful the PowerPoint slides are, do they work in the real world? I think that's where I think Fang Fei's question was about validation. And Fang Fei, I just want to make 2 points about validation. I think that is hard validation. That's a kind of validation that Dr. Goh has talked about. But there's also soft validation. And by soft validation, I mean, you can publish 20 papers saying that your biomarkers, your feature selections have wonderful performance metrics. But I think the soft part has to do with what is the reputation of this group? Are they people whom we can trust? And, we all have an intuition about people and places that we need to be careful about, regardless of their publications. So Fang Fei, I think it's both the science of validation as well as the reputational aspects of who was doing the reputation in how many places, in how many geographic locations. So I've said my piece, but I just wanted to get this off my chest, as it were.
No. Thank you, Professor.
Thank you. Thanks for Dr. Kwong.
Yeah, that was very insightful. Thank you so much.
Yes. Yeah. So to echo Prof. Kong's point, the reason why genetic testing, the DNA and RNA mutation or expression profiling is widely practiced in America is not only because it can potentially differentiate between benign and malignant nodule. That's number one, right? Prof. Kong's first step, right? Binary, and also there's some prognostic impact on the test result. So, for example, thyroid sequencing result can tell you, oh, there's not only BRAF V600E, but there's TERT mutation. And we know TERT mutation portends a poor prognosis and usually aggressive cancers. So then the patient with a small papillary thyroid carcinoma may undergo total thyroidectomy and radioactive iodine because of the TERT mutation, versus a hemithyroidectomy if it's just BRAF V600E mutation without any other clinical adverse features. Yeah, so this is one reason why these tests are kind of attractive to clinicians. Yeah, I won't say that they're totally accurate, but attractive.
So Dr. Lee, let me just cut in here. The Western countries, the US in particular, they love sequencing DNA because a robot can sequence DNA. It's cheap. It's almost low tech now to sequence DNA. But I think it's good for all of us to read the full 2022 update of the WHO classification of thyroid neoplasms. I read an abstract of it. I read an overview of it. I think the actual report is not yet out, but it seems as if the 2022 review of thyroid cancers, somewhat to my surprise, was very unenthusiastic about mutation screening because it's not universal. You may or may not have that BRAF mutation. Not everybody has a TERT promoter mutation. And I think they cite references which show that the BRAF mutation, in fact, is not prognostic.
Yeah, that's true. There's a controversy about BRAF mutation. That's why I said, if it's just BRAF mutation without other clinical adverse features, this can still be treated as a low-risk cancer.
Yeah.
So certainly I think that the key question from a patient's perspective is, first, is this benign or cancer? And second, if it is cancer, will I die from it?
Yes,
so
exactly.
That is important, especially in old people where they have competing interests. They may choose active surveillance. So it's very exciting that in Japan and in New York and in Korea, they have actually observed papillary microcarcinomas, and they don't treat. They don't do anything. They just observe with ultrasound, and up to 20 years in Japan, for example. At 10 years, only about 8% grew by at least 3 millimeters in size, and only about 4% developed metastasis, and none of the patients died. So then these are very insightful information. So what are we actually doing? We are diagnosing, or ruling out cancer to reassure the patient, but at the same time, we must remember the big picture is will I even die from it? And therefore, how and after treatment, the other question is whether the cancer will recur. Yeah, so these are things that if we can predict precisely, it would be very impactful.
Yeah, so you don't want to be that 4% who will have metastatic disease. That's the point.
Yeah,
and that's the challenge for us to really identify that 4% whose microcarcinoma is going to metastasize. I'm just going to be a little unkind to you, Dr. Lee. In your last slide, you said there were unmet needs, and you had 3 bullet points.
Yes.
You remember your last slide, 3 bullet points.
Yes.
If I said you could only have 1 wish,
Okay.
what wish would it be?
Yeah, I feel that the strongest unmet need is in ruling out follicular type of thyroid cancers. That's because they lack distinct sonographic features or distinct cytological features or genetic features, right? And yet they are more lethal than papillary thyroid cancers. They can present distant metastasis. They do have a serious risk to life. So we end up doing a lot of FNACs just to make sure that they're not follicular carcinomas. Yeah. A lot of diagnostic surgeries. So I really think this is the strongest unmet need.
Yeah. So I would recommend the Westlake University Proteomics group. They're going to solve your problem.
Together we can solve this problem. So here I'd like to ask the question from a different angle. There are so many cancers from almost every organ, but there are very, very few like thyroid cancer. Some people say if one is destined to have a cancer, then thyroid cancer is probably the best choice. So why thyroid cancer is so benign? Why liver cancer or breast cancer is so malignant compared to the others? From your point of view, I don't know whether there's any evidence, or do you think how we can approach this question? I mean, a question for all of you, if you have any idea.
Tianan, I think that's an extremely important question, but you could ask that question, for example, of basal cell carcinoma of the skin. Basal cell carcinoma is a little bit like thyroid. Most of the time, it won't kill you. Squamous cell carcinoma is a different beast. You know, that's a fascinating question, Tianan. And I read a review which refers to the TCGA study many years ago on papillary thyroid cancer. And whoever wrote this review, and I forget who it was, they compared the transcriptome of papillary thyroid cancer in that TCGA series, which is more than 30 types of cancers. And they said that among the 33 types of TCGA cancers, papillary thyroid cancer transcriptome was the most quiet in terms of mutations. So it may be that we don't need a mutation to drive oncogenesis. We just need an imbalance of networks. I mean, we've all been sort of brainwashed into thinking if there's no mutation, you know, you're fine. That may be wrong. I mean, the networks have to be in a kind of ballet, you know, it's a choreography. And if the choreography goes wrong, you don't need a mutation.
I'm thinking about if we can have some measure which can sort out the aggressiveness of different cancers. And based on the published data, omics data, probably Wilson can do some network analysis to see, in addition to the number of mutations, how the network differ and how this correlates with their aggressiveness, and what's the special thing for most thyroid cancers.
Or mutational loads versus, right, you know, overall dysregulation, you know, I mean, if the networks are dysregulated, it could manifest in a few ways. It could be that they are all amplified, but the ratios of balances are still preserved, or that they actually break against the natural order of what you observe, right, in most other cancers that, you know, are of a different nature or in normal human cells. So those are interesting questions that could be tested, I think, you know, using analytics approaches. You know, that could be a very interesting angle to pursue as well, I would think, yes.
Actually, recently our lab has generated timsTOF DI-PASAF data, very deep proteomics data. We analyzed over 1,000 samples, and half of them are benign and half of them are malignant. There are more than 20 types of different cancers. Probably this can be a very good data set for you to analyze why some cancers are so benign and why the others are not.
Tina, let me try and jump in here again. If you're looking at many different cancers, you know, a pan-cancer study, I think you can think of it as being in a party where there are many conversations going on. In cancers, the loudest conversation is cell proliferation, because that's the common language of all cancers. But as you know, in a party, the people who really matter are the people who talk softly.
Yes.
And so you really, I think for network analysis, I think we have to discount the loud voices because you hear them in every cancer, and they are not going to give you that biological explainability, which we all crave for.
Yes.
Right, because that takes us deep into the thing. So I'm just wondering whether, you know, thinking of it like many conversations at a party and being smart enough to know which conversation to listen to. And I would guess it's the soft conversations.
Prof. Connor, I would jump in here because actually we recently published a paper also talking about proliferation as a confounder in breast cancer, confounding breast cancer diagnosis, what do you call it, prognosis predictions as well. But I would like to also mention, right, that proliferation genes are a very big set, and not of them, right, while many of them correlate, you know, with cancer prediction, not all of them are useless as well. In fact, depending on which literature you look at, there are some, right, which reports a very small number of high confidence proliferation genes, and there are others, right, which reports as much as 1,000 over of these as well. In our analysis, we actually found, right, that not all of them are useless, and some of them actually do have very powerful universal predictive properties as well. So I think one of the challenges, right, is to also try to separate, I think, the wheat from the shaft, and to not just basically just say that, yes, just because, right, you are branded, right, as involved in proliferation, therefore you have no predictive value as well. I think it's very important that we try to understand that some genes can actually serve multiple purposes as well.
Yeah, I think that's an excellent point. And I think we tend to think about cell cycle genes as only being for the cell cycle.
Yes.
And I think the other, I think words can trick us and mislead us. I think when we talk about cell proliferation genes, perhaps different people mean different things. For some people, it's a huge basket,
Yes.
which includes many networks that are required for cell proliferation. But for other people, it may be just, a little cup of genes. So yes, I take your point, and I think that's but that's the challenging thing. We look forward to more of that kind of work.
I think also there's a lot of biological mechanism to be investigated, because now there's only focus on BRAF V600E. That's a very common markers in non-specific cancer markers. I think just because there are sequencing machine and people test that, and yes, you get the RAS mutation or TERT mutation. But I think that's coming to the Dr. Guo's questions, why the thyroid nodule is not that severe. Maybe there's some biological or evolutionary interesting site that we can discover why it's not that serious for the thyroid.
But Fanfei, I think it would be even more interesting to compare microcarcinomas that never grow, that never kill, with microcarcinomas that do become aggressive. I think that would be a very insightful comparison.
Yeah, we have another project which is to answer this question. So I was thinking about, when we see a nodule, means it proliferates, it ever proliferated, because it's bigger than the normal thyroid cells. And then somehow maybe it stopped growing further. But for those lung cancer, they continue to grow and without any stop. So probably there's some mechanism which can stop the early proliferation or early uncontrolled proliferation in the thyroid. What can that be? Maybe an immune system, or maybe due to the metabolism, or is this due to the origin of the first cell which have an uncontrolled proliferation, so that you can have different types of thyroid nodules and thyroid cancers? Do you know any literature on this regard, Braden?
Oh, no. This is too
Probably a clinician.
Also, the other day, Dr. Lee asked me if we can identify thyroid-specific plasma biomarkers. I think we have tried kind of project like this, but we didn't find that yet, right? Can we identify something like this?
Yes. So that's because the aggressive thyroid cancers can metastasize, right? So if we have to do surgery to rule them out, then it's probably not as good as a blood test that can detect such metastasis. Yeah, but I don't know whether that's feasible.
I think looking at blood, right, is going to be even more challenging. In fact, we are actually trying to propose, you might know you, right, also from Tan Tock Seng Hospital, but we are actually trying to understand, like how molecular changes or molecular predictive markers, right, in the breast tissue, right, could be correlated also, right, to signals that we can find in the blood, that are objectively so. But I think that project has proven to be very challenging. So I'm not very confident or sure if this is something that is indeed feasible as well. But I think if it were feasible, then I think it does open the road to, I think, less invasive diagnosis as well, or constant monitoring. Yeah. Do we have a time limit for the panel?
I think already past the time limit.
I'm pretty sure we did. But it
Also,
was
we
very, it
finish
was
at
very
8:30.
Yeah. We should let
Yeah.
your audience go, you know.
I really enjoy this discussion. You came from two very different fields, and I'm from a third field.
Yeah.
And we had a very, I think we can collaborate together to make Brandon the best surgeon.
No.
When, and know when not to do the operation.
Make all surgeons as good as
Mm.
Okay.
So thanks so much. Maybe it's good time to end this discussion, but we can keep discussion maybe on email and in future events. Thanks a lot, and
Thank
have
you
a
for
nice
having
evening.
us. Thank you
Yeah,
so
bye-bye.
much. Good night.
Thank you. Bye.
Bye-bye.
Okay.
Bye-bye.
Thank you.